or we need a staging PET CT. I'll do staging for the PET CT. So since CT plays the most important role in, you should always know what to guide them. You should always know what should be the staging based on the size of the tumor. So you should always know it has to be T1, T2, T3, T4 classification. It should be handy with you. You should know what is the, so anything with less than 3 centimeters is T1, 3 to 5 centimeters is T3, 5 to 7 centimeters, anything more than 7 centimeters is T4. But based on the involvement of the adjacent structures, it becomes operable, inoperable. You are actually the ones who decide the management, because the surgeons will come to you, the radiation oncologists will come to you, they will ask you these questions, so you have to know them. So there is a very important thing to know. If you see a satellite nodule in the same lobe, it is T3, it is still operable. If you see satellite nodules in the same lung, it still, it does not become metastatic, but it's still not operable. Coming to the, which is one thing which is very important, nodal staging. So nodal staging, if N1 and N2, that also decides if the patient is still to be taken for a surgery or not. So you have to report N1, N2 separately. You don't please, so one thing which we do is we mix up the report the active nodes separately. We have to report the negative nodes, the metabolically inactive nodes separately. Ipsilateral nodes, active nodes, so we report them as FTG or metabolically active nodes. If they are peribronchial nodes, hilar nodes, intrapulmonary nodes, they are to be reported as N1 nodes. If they are ipsilateral mediastinal nodes, subcarinal nodes, they are N2 nodes. Anything you see on the contralateral side, mediastinal node or hilar nodes, or anything in the supraclavicular nodes, they become N3 nodes. And anything on the distant side is a classification which has been given by the American Thoracic Society NAMPICON scheme. So often our pulmonologists, they have to do an EBUS. They come to you to guide you that which is the most accessible. They come to you to guide you that which is the most accessible node, because they have patient and they have to give the know which is the most as such. No bronchial invasion, no vascular invasion. The surgeons deemed this subcarinal node were active. And there was a small thoracic para-aortic node, paraesophageal node was also there. So in such cases, you have to be very, very sternly, you have to tell them that, and you have to report all these nodes, because you have to tell them, because although the lung mass looks operable, the nodes can be positive. Most of the nodes, although they showed calcification in our Indian population, the negative predictive value, positive predictive value for say these are inflammatory nodes. They did an EBUS, the few of the opposite nodes actually came out positive, and the surgery was, they did not go ahead for surgery. Just by seeing the nodes, they were actually first. The transfacial growth,